The following content is provided under a Creative Commons license. Your support will help MIT OpenCourseware continue to offer high-quality educational resources for free. To make a donation or view additional materials from hundreds of MIT courses, visit MIT OpenCourseware at ocw.mit.edu.
I always get a little afraid when I hear somebody call me an expert, because I think that's a term you should fear. I want to consider myself a learner and be in that journey with you all today. Before we get started, I wanted to also tell us about or have our guest introduce themselves, if she doesn't mind. Florence Hazeltine is the Director of Population Studies, Director for the Center for Population Studies at the NIH. And she's an advisor to SANA. And would you like to say just a few words about what you're doing? And
Course 7, and I continuously lose my brass rack.
Great. So Florence is here. Take advantage of her. She's just developed, she was telling me just before class, some wonderful apps, for iPhone, and I'm guessing the iPad as well, that have to do with contraception. Really, really good stuff. So good resource for you. We're going to be talking about quality improvement a bit today. We're going to be talking about how to engage in quality improvement. As we go, if you have questions, please feel free to stop me. I'm very informal generally as a presenter, and I'm used to presenting to groups who are working in small tables and less in a stadium theater style presentation. So what we're going to cover in brief, I'm going to tell you a little bit about quality improvement, where it has its origins. We'll talk about how it came to be in healthcare. I'll tell you a little bit about the Institute for Healthcare Improvement. We'll talk about the system of profound knowledge. Anybody ever heard of the system of profound knowledge before? Nobody? Okay, good. So that'll be new. We'll do a little bit on systems thinking, and then we'll talk about something called the model for improvement. We'll wrap up with that. So as we go, please feel free to engage in questions. All right. So brief history. There's 2 or 3 people that are incredibly important, and you may recognize some of these faces. So the 3 kind of people that are often credited with the creation of quality improvement as a discipline are Walter Shewhart, Edwards Deming, and Joseph Juran. Both Deming and Juran were students of Walter Shewhart, and I think Leo mentioned a bit about this before, but Walter Shewhart was a statistician who was working in the early part of the last century. And he is responsible for something we call statistical process control methods. So he took statistics in a new direction, took it away from classical sort of descriptive statistics, and looked at how we could understand systems over time. Could we get to a place where we could understand performance and actually predict performance based on stable systems? So this is Walter Shewhart. And he was a very, very deep thinker in that regard, although he wasn't really interested in healthcare. He was mostly focused on manufacturing. His pupil, and the person we're going to talk most about today, was Edwards Deming. And Deming took it a step further. He was also a statistician. He learned quite a lot from Walter Shewhart, and they wrote a couple of books together on the subject of statistical process control. But Deming actually thought that there were some other things that were going to be critically important, not only to understanding systems, but if you wanted to change systems, if you wanted to make them better, what was the knowledge that you needed to leverage in order to do that? Right? And we're going to talk more about that. And he gave us what we call the system of profound knowledge. Joseph Juran was also a very important thinker at the same time period, and he focused his efforts on 3 different things. Whereas Deming was focused almost exclusively on quality improvement, Juran had what we call the Juran trilogy. He was focused on 3 things: quality assurance, quality improvement, and quality design. And so he was interested in designing systems, assuring that they were achieving the stability that was called for by the customer, and then figuring out how to improve upon the quality of the product or service that system was seeking to serve. Okay. So those are sort of three important people. Deming did a lot of his work in Japan after World War II. He worked with our U.S. military during the World War II, and then afterwards with the rebuilding of the Japanese economy. Have people heard of Deming before? A couple people? All right. Yeah, good. So how many have heard of Toyota Production System or lean manufacturing? More people have heard of that. All of that is an outgrowth of what he started in Japan in the early 1950s, and we're going to talk a bit about that today as well. So, Deming's system of profound knowledge, most aptly described in his book, The New Economics, which was published in the early 90s, just shortly before his death. Deming was a person who was absolutely passionate about quality improvement. He lived to be 93 years old. He gave his last 4-day seminar on quality improvement at the age of 93, 2 weeks before he passed away from a wheelchair on oxygen. He made it his life's mission to focus on improving systems. He felt that there was a tremendous amount of waste and inefficiency that existed in systems, whether they be manufacturing, service industry, or later in his life, during sort of the last decade of his life in healthcare. And he gave us the system of profound knowledge, which I'm going to describe in a second. Before I do that, though, I want to talk a little bit about the Institute for Healthcare Improvement. So Deming was holding one of his 4-day seminars in 1987, and there was a doctor in the audience by the name of Don Berwick, who Leo introduced us to a couple weeks ago. Don was working here in Boston as a pediatrician, and he was seeing that a lot of patients were being harmed in the hospitals where he was working. And he also knew internally, no matter how hard he worked, he couldn't always provide the same level of quality of care to every one of his patients. And that bothered him as an individual. Right? And so he was looking for answers for that. And he actually went and attended Dr. Deming's seminar for 4 days. After the first day, he thought, this guy is crazy. Got on a plane, flew back to Boston. In the middle of the night, he had this epiphany that actually there's something to this systems thinking. There's something to quality improvement that I need to learn about. He flew back the following morning on the early morning flight, finished the seminar, and at the end of that, he developed an idea for a demonstration project. And he sought some funding, and he partnered 16 hospitals in the Boston area with industry leaders in quality improvement, people who had been using Dr. Deming's methods for years and years. So he would partner people with electric companies and manufacturing companies to see how they could learn about quality improvement and bring that into healthcare. That demonstration project lasted a couple of years, and at the end of it, there was a lot of really good learning about how we could improve systems of healthcare. So we decided to create IHI at that time, so that was in 1991. And IHI is based here in Harvard Square, has been working on improving healthcare systems using quality improvement methods for the last 20 years or so. So I've had the opportunity to work for them for the last 5 years or so, and as Elliot pointed out, I've been doing that mostly in resource-constrained environments. And I think that's really where quality improvement is at its best, in places where you've got to optimize what you have, because you don't have anything extra to give. So what is quality improvement? What is the system of profound knowledge? Okay. System of profound knowledge is a way of looking at an organization or a system that's trying to provide a service. So if I'm looking at a healthcare system, a single hospital, a clinic, or even a whole national healthcare system, right, I can use this sort of a lens, if you will, as a way to understand performance. Okay? And Deming argued that there were 4 really key components here. Okay? The first was appreciation of the system. Do you have a way of viewing all of the processes that exist within a system, all of the work that is happening on a day-to-day basis, work that's happening between caregivers and patients, between managers and caregivers, between support staff and each other, right? All the different things that are happening. Do you have a way of articulating that? I'm actually going to introduce you to a mechanism for that this morning. So appreciation of the system. Do you have that view? Can you see everything at once? Because if you get busy trying to improve one thing, you can actually suboptimize the whole system. He also knew that there was the importance of data, right? The importance of understanding variation and understanding stability. That's where he got his start with Walter Schuhart. So he knew that you needed to be able to understand each process and measure it and understand if it was predictably performing into the future. We're not going to touch so much on that today, although I would like to. I think it's a really fun topic. Deming also knew that psychology was incredibly important. Motivation. What gets people to work in the morning? What gets them doing things? What gets them excited about their work, right? So he knew that psychology was critically important. And there's a piece of this which is sort of the culture of an organization. Is it a punitive organization internally? Is it one that rewards innovation? Is it a learning organization that encourages people to constantly be testing and learning, failing often, right? So he knew that that was going to be critically important. And the last piece he had was the theory of knowledge. We're going to talk a bit about that as well today. Theory of knowledge, sometimes people call it epistemology. Sometimes talk about the scientific method. I like to think of it as this way, can you articulate what you believe about why things are the way that they are? Okay. Can you do that? If you can, that's great, because it gives you a testable starting place. Right? Because whatever you believe is going to influence what you decide to change when you go to improve a system. If I am doing some work in South Africa and I believe at one particular hospital that the reason we have poor outcomes for our patients is because nurses are lazy, then that's going to control what I decide to change. I'm going to do something to remove the laziness of nurses. Now, I do not actually believe nurses are lazy. I think they're the hardest working people in healthcare. But if I believe that, if that's my theory, if that's my starting place, then that changes what I decide to change in a system. If I instead think that it's a process orientation problem, or it's a problem with physicians, or it's a problem with technology or resources, then that's what I'm going to go after. A lot of people never get to the place where they articulate what they believe about why things are the way that they are. They internalize assumptions, and then they start towards solutions based on those assumptions. Often we hear about, especially in resource-constrained environments, I'll tell you what we need. We need more hospitals. We need to build more hospitals. Right? What's the underlying assumption? That the infrastructure is inadequate, right? And then there's even further assumptions behind that about why the infrastructure is inadequate, right? We hear we need more healthcare workers, right? We need more money. What we know from U.S. healthcare is that's not likely the case, right? Leo told us about U.S. healthcare, right? We spend twice as much money as the next country to get not as good care. So it may not be a resource issue, but we need to question that. If that's our starting place, we need a place to start testing. So the theory of knowledge. So these four components, which are driven by the values of the organization that we're looking at, right? We're going to leverage those along with something we call subject matter expertise. So Florence and I were just talking about this. So important. It's really important to have somebody who can think from an improvement perspective, who can leverage the system of profound knowledge, but we also need somebody who's a subject matter expert. Right? If I'm going into Ghana and I want to help the country of Ghana to reduce under 5 mortality, then I need to be working with some people who know about under 5 mortality. I need to be working with some real experts in that environment. Clinicians, nurses, doctors, counselors, people who are working with communities who understand the context and understand the culture where I'm working, right? And I need to combine that with profound knowledge, with this ability to look at psychology, to appreciate the system, to articulate what I believe, and to understand performance, right, if I want to achieve improvement. So it's where those two things come together that we can actually take quality improvement forward, right? Unfortunately, most of us in our formal education, we just learn this. We learn subject matter knowledge, right? We go through our formal education becoming ever more expert at a particular thing, right? So Florence, you told me you're a physician, right? What type of gynecologist, right? Leo, also a physician? ICU, right? Would you feel real competent delivering gynecological services? No? How about vice versa?
We think we can do anything.
Yeah, right. The idea there is medicine is especially prone to this specialization, right? We're constantly learning more and more information, getting more and more specific about what we can do and becoming the best at that. But that comes at a cost. It comes at a cost of not understanding the culture, the motivation, the performance, without the ability to see the big picture of what's going on for the whole health system, right? So bringing those two things together is critically important. Does that make sense to folks? I get so scared when it's such a silent audience. Okay. Any questions on this so far? All right. Okay, so here's what I want you to do. I know a lot of you have computers, so maybe bring up a spreadsheet or OneNote, Word document, something like that. Do it in your head. For those who have paper, get out a sheet of paper and a pen, okay? Here's what I want you to do. Okay? I want you to choose a number between 3 and 9. Write that down. 3, 4, 5, 6, 7, 8, 9. Okay? You have a number? Yes? All right. Okay, good. Yeah, there we go. All right. I like Peter. All right. Next step, I want you to multiply your number by 9. Okay? You got that? So if you had 3, your new number is what? On the spot. 3 times 9. 27. Good job. I'm with Leo. I need the calculator. All right. I want you to add 12 to this new number. Okay. Got it? Fast. All right. All right. Okay. Everybody have a 2-digit number? Just real quick. If you ended up with something over 100 or under 10, we're in trouble here. Just want to make sure. Okay. I want you to take those 2 digits and add them together. So if my number was 18, I would take 1 plus 8, and that would equal 9. You got that? All right. Math is almost done for the day. I know you guys weren't expecting that this morning, early in the morning. All right. Divide that number by 3. Should have a 1-digit number. Everybody got a 1-digit number? Okay. All right. Now, whatever your number is, I want you to convert it to a letter. So if your number is 1, you now have the letter A. If your number is 2, you have the letter B, and so on. Have you got your letter? Okay. I want you to write down the name of a country that begins with your letter. Okay. All right. Next step, whatever your letter was, I want you to take the next letter in the alphabet. So if my letter was A, my new letter is B. Okay? So take that letter. I want you to write down the name of an animal that begins with that letter. Okay? So it can't be a bird or an insect or a fish. I want like a land-dwelling mammal. Got it? All right. Last step here, I want you to write down the color of your animal. The color of the animal. Okay. All right. You all with me? Ready to go? Okay. Annie, what country did you have? Denmark. What animal did you have? Elephant. What color is an elephant? Gray. How many people had a gray elephant in Denmark? Wow. Wow. That's incredible. Now, Annie, one quick question here. What number did you start with? 6. Did you all start with 6? You started with 6, but no. What was 7? 5, 8? Right? Wow, amazing. So there's some variation here. There's a few people who might have gotten something different. But what happened? You had some free choice here. You could have chose any number, right? You made the decision. What happened was the process took over, right? We put you into a process, and we started the process started to make decisions about what your outcome was going to be, right? Now, in any given room, about 9 out of 10 people are going to get a gray elephant in Denmark. Okay? You get a few people who are going to get an eland in the Dominican Republic or something like that, right? But that's pretty rare, right? And this is an important lesson that Deming gave us about appreciation of systems. Okay? So Deming argued from a statistical perspective that about 95% of all the variation we see in stable performance of systems is the responsibility of the system itself, not of the individual workers, right? That's only about 5%. Right? So a lot of times we hear admonishments, if people just worked harder, maybe if we paid them a little more, right? Maybe if we punished them, then we'd really get something done, right? The reality is that's not the case. It's the system that controls the outcome. So if I'm in a resource-constrained environment and I see really high mortality rates, let's say I'm in Ghana and I have 80 deaths in children under the age of 5 for every 1,000 live births, right? That is a product of the system that I'm in. Right? It's no one person's fault. It's not laziness on the part of the workers. It is the system itself. Right? Leo introduced us to the concept of every system being perfectly designed to achieve the results it gets. That's what he's talking about right there. Okay? That's what he's talking about right there. Does that make sense to folks? This is an incredibly important concept when you start to think about quality improvement. Right? Because quality improvement needs to be leveraged on the system, not on the individuals. So let's do another example. Leo, come over here. You're a pretty healthy guy, right? Okay. Exercise frequently? All right. Leo, I want you to jump up and touch the ceiling. Can you do that for me?
They can't see it though.
No, go ahead. Just give it a jump. Give it a shot. Seriously. All right. That wasn't too good. I don't think he's properly. I don't think he's properly motivated. Leo, here's some money. If you can touch the ceiling, you can have all that money. You think you could do it?
With some contraptions.
Right. It's a system, right? We talk about pay for performance. You can't really pay for performance when a system is controlling the outcome, right? There's no way he's ever going to touch the ceiling, right? Not just from a standing jump. So it's incredibly important to have that systems view. What I want to introduce you to is a tool that Deming gave us for starting to develop that. Now, we're going to look at it conceptually, but you can do it very, very specifically for any system that you work in. Okay. So what is a system? It's a collection of processes working together towards a defined output. That's how we would define that, right? So, and Deming would argue it's where you draw the circle, right? It could be a single process. It could be, say, something like antenatal care, which is a single process. Or we could take into account labor and delivery as well, even postnatal care. Now we're grouping a set of processes together that are working towards a defined output, which might be a healthy child, right? We might even say it's the continuum of care from birth through death. So now we're talking about everything. We're talking about chronic disease management, we're talking about acute care settings, emergency settings, all that can be put into a system. Right? You get to decide. The larger you draw the circle, the more complex the interactions are going to become. And so it's more and more important to have the ability to see what's going on. Now, I think, Leo, you attributed this quote to Don Berwick, and I'm attributing it to Paul Batalden, and they're very good friends. And both of them say that the other person said this. So it's quite funny. They argue about it all the time. So I figured I would do the different one since you said it was Don's. All right. So what's the best tool for understanding systems? Right? There's lots of tools we can use. We're going to talk about 2 this morning. All right? But it's really important that when you approach a problem, a systems problem, that you have a perspective of which tool. Right? Has everyone ever heard the saying, when all you have is a hammer, the whole world looks like a nail? Right? So important when you're approaching a systems problem to approach it with a series of tools and try to choose something that's going to work appropriately. Okay? So what I'm going to introduce today is Deming's linkage of process. This is adapted from Associates in Process Improvement, a group of his students who have taken his work further. And linkage of process is a way of viewing all of the work that is happening within a system. Deming argued, he said one of his famous quotes was, all work is a process, or all processes is work, one of the two. He said an organization starts with a purpose. Okay? A system starts with a purpose, and we need to define what that is. What is that particular thing? Why do we exist as an organization? Okay? Do we have a sense of that? Okay? That's going to control what our outcome will be, what our what it is we're going to produce for our clients. So that's important from a healthcare perspective. That might be what? Say that again? Yeah, improved health status, right? Right. We ever heard of health for all? Things like that, sort of vague things, right? Or it could be something very specific. It could be a particular outcome from, say, a surgery. Okay. So whatever it is, we want to be very clear about what it is that our outcome is, the outcome that we want to deliver. Okay? Now, Deming said that there is work that we do that is focused on producing that outcome. So let's take maternal mortality. I know that's an issue for a lot of folks in here, and that people are interested in early childhood mortality. And it's something I'm interested in. Okay, there are things that we do. We provide antenatal care. We want to get people in early. We want to get pregnant women in early and identify them as being pregnant, and then start delivering a set of services, immunizations, care, monitoring their pregnancy, right? There's a certain level of patient care that's taking place. Deming called this the mainstay processes. Okay? These are things that you are doing to get the outcome that you want. Right? If it were surgical care, it would be doing the surgery, going into theater with the patient, surgical team, delivering the surgery. Right? Does that make sense? No? Yes? Okay. So we could map each one of those processes. Right? There's a process for registering the patient. There's a process for their first visit. There's a separate process with a whole bunch of steps for their second visit, third visit, et cetera. Okay? And all of that is the mainstay, leading to a particular outcome. In order to do that work, we need supplies. Right? We need an environment to work in. We need the people, the workers who can actually do the work. Right? There's their education. There's the drugs that we need, the pharmaceutical stuff that we take advantage of. All of that is going into our mainstay in order to provide care to our patients to get the outcome that we want. Right? And all of that can be articulated as well. Each one of those processes has a whole set of steps that we can look at. Does that make sense? And one process leads to another. Yeah, straightforward. Okay. Well, here's where it gets a little more complicated. Okay? Now, there's some other things that are going on, right, that have nothing to do with actual patient care. Right? Now, they're related, but they're different. Right? They are not the business of delivering the care. One of those things is the business of monitoring the delivery of that care. Right? So we have measurement and feedback should be a part of a system. Okay? And that's the part that I think we're focusing on very closely this semester. But how do we get that right? Right? And there's sort of two voices here. There's the voice of the customer, right, which is a work that the customer is telling us about how well things are going. Right? If we're providing surgical care and our patients are dying on the table, what's the voice of the customer telling us? We're not doing too good. Right? Mortality's high. That's not good. That's not what we want. Right? In Ghana, where we have high under 5 mortality, right, we know we're not doing too good. The mortality data is telling us that we need to be doing better. Okay? We also have the voice of the process, okay, or the voice of the system. So we can measure our ability to provide care. And we do that all the time, don't we? We look at things like wait times, patient volumes, throughput. We look at patient satisfaction, which would be on this other side, looking backwards. Okay? So we have these two things that we're measuring, the voice of the system and the voice of the customer. Okay? Another part of a good system, yeah?
So is it necessary to internalize those feedbacks if we have a theory of change, or how to match theory? Can we internalize both our assumptions and those feedbacks if we have a theory of change, if we want to change the
Sure.
system? At which level it should be balanced, those two, the feedback and the personal assumption?
Definitely. Definitely. So I think what you're describing is the interaction between understanding variation in our system and what we believe about why things are the way that they are. So we're gonna try and articulate that. We're gonna write it down somewhere, maybe in a project charter, okay? And we're gonna lay out a set of measures that we think will be important. So if I want to reduce under 5 mortality, one of the things I need to do is measure under 5 mortality to see if I'm reducing it, right? If I'm consistently trying to change things, motivate employees, build a new hospital, buy some ambulances, then I'm going to be looking to my outcome measure to say, is it working, right? Is it working? Now, if under 5 mortality just stays constant, predictable, stable over time, how does that change my theory? Right? So that would tell me my theory is wrong. There's some learning that needs to go on. I built all these hospitals, I bought all these ambulances, I motivated all these people, mortality stayed exactly the same. Well, guess what? Those weren't the answer to changing mortality. Something else is involved. So now we have to evolve our theory, right?
It could be complicated in cases where
So that's exactly right. And that's where the learning begins. So if we're doing quality improvement, we want to then change our assumptions. So when the data starts to tell us that our assumptions are incorrect or incomplete, then we need to add to them or we need to evolve them and then test again and test again. And we're going to see that in just a second. Yeah, that's a great question. That's right on. So another part of a good system is looking to the future, right? So Deming called this market research, right? We might call it foresight, right? If we look at health systems globally, for the last 100 years or so, most of them have been built to focus on acute care. Right? People get sick, they go to the hospital, we admit them, we get them better, we send them home. But what's coming next? What's the big issue that's coming? Yeah, chronic care, right? Think about Africa, right, for a second. HIV, big problem there, right? It used to be, for the last 10, 15 years, we were really focused on delivery of antiretroviral medication to people in Africa, right, in an acute care environment. And suddenly we're waking up to the realization that we've got to actually provide chronic care to these same people indefinitely. Right? And that's really, really important. It's really important to have the foresight and to have a mechanism for looking for what's next. So if we want to continue to be relevant to our customers, to our clients, we need to be paying attention to what their needs are going to be, not just right now, but what they're going to be in the future. Yeah? So having that process of work articulated for any system is important. And if you look at really successful organizations, whether they're health systems or corporations or whatever, they have that. They're looking to the future. Right? Some of them, in the case of like Apple and apps, they're inventing the future. They're telling us what we need before we know we need it, right? Okay. All of that needs to feed into a mechanism which is a plan to improve. Right? We want the ability to improve something. We need to actually have a mechanism for doing that. We need to have that in place. Okay? And then we actually need the work of doing that. Now, all of that is different from delivery of care to patients or manufacture of product, right? That's all different. That's not the work of the caregivers. Who's that the work of? Who does that stuff? Who has the power to change a system? Is it the nurse? Yeah. It's that minister of health, right? It's that CEO of the hospital. It's those senior leaders who had the ability to say, actually, we're going to change our policy here. We know that we need to do something different in the future. Okay? So this is the role of management. And that role of improvement and redesign constantly is the role of management. Workers can help you understand where the process is broken. They can tell you when you're getting that gray elephant, when what you really want is a pink elephant, right? But it's up to the managers to empower the workers to begin to make changes. Okay? So that's going to be a critically important concept. There's one other thing that's missing. If I'm providing surgical care, and I bring in my first patient of the day and get my surgical team in there and do surgery, and then I wheel them on out to the ICU to get better, and I go back in, can I just go ahead and start another surgery? No, we got to have somebody who comes in and cleans up, right? All that blood and guts and stuff everywhere, and infection could be rampant. That's not good. So we have a whole set of support processes. We have a whole set of work that's focused on empowering our ability to provide the mainstay, right? All the things that we need in order to keep the day-to-day running well, right? So those can be things like maintenance, IT, finance, all these types of departments that are critically important. They don't actually provide care directly to patients, but they create the environment by which we can provide care to patients. Now you'll notice there's no chronology here. There's no beginning, there's no end. It's quite circular. That's important. Yeah.
Sorry, jump back a little bit.
Sure.
I think it's really crucial, like this balance between the feedback and the assumptions. A lot of time in the field, like when big organizations or even governmental agencies, even though their assumptions are contradicted by the feedback, they still keep those assumptions and they continue. And we have lack of sustainability, and I think everyone knows it, it's a really, really big problem everywhere.
I couldn't agree more. It's a tremendous problem. And why do you think that is?
Because you're going on a wrong direction. You're putting resources, wrong direction. It won't benefit the people you're trying to serve. Or it's even more profound. It's like this when we were saying about the profound knowledge, and it could even go beyond where this top-down developed countries versus like the poor, the developing countries. So like all the knowledge is on the developed countryside. So sometimes they say those feedback are not relevant. They don't have. We can't trust those feedbacks because they don't have the knowledge. We have the knowledge, so we'll just continue. So it's a big,
Yeah.
problem. How
Yeah.
we see the people we're serving also. Do we trust them? Do we trust their capacity? Do we trust their feedback, the way they process all the things that are happening to them, their environment to produce those feedback? Can we trust those feedback?
Yeah.
Can we trust their capabilities? So it's a big,
It's a huge issue.
can we see them as we are?
Yeah.
Even though we could have more education, but it's a lot of, it's really a big
I think it is a deep problem, and I think what you're describing in my mind is a disconnect between the feedback that's coming through and people not being receptive to it. We've got 50, 60 years of case studies of development projects that have failed. Right? They haven't done well, and we haven't done a good job of learning from that failure. Quality improvement at its core is about failing often to succeed sooner. It's about learning from failure, establishing feedback mechanisms that we can learn from, rather than putting the blinders on and just going with our assumptions. So we have to be open. If we're going to be doing quality improvement, we have to be open to constantly learning. And if a project fails, we need to actually say, why did it fail? Was it because we had bad assumptions? Maybe. Was it because we had bad people? Probably not, right? It's those things. What's hard is getting leaders in place who have that perspective, who have the ability to have a systems view and to actually understand how they can use data to their advantage to manage and redesign their systems. That would be my thinking. But I see it all the time. I think you're absolutely right that there's some real deep issues that need to be tackled. But in my mind, it's got to start up here. It's got to start with the leadership to be able to engage and learn about that stuff. Yes?
I want to propose a simpler reason for the disconnect between assumptions and feedback. In some cases, it just takes a lot of money to get these systems in place and working. So the leadership would rather not change the system. It has cost them so much. In spite of the feedback they are getting, they will tell you, oh, these are just maybe teething problems. People don't like change, people get used to it and stuff. But underlying everything is the fact that this system has cost a lot to establish, and we cannot just do it, even if it's more.
Yeah, you may absolutely be right. I think one thing that's critically important when we think about quality improvement is we're talking about continuous redesign of an existing system, right? So it's important from our perspective, if we're going to be advising people or we're going to be helping them to improve, that we're not necessarily proposing to eliminate everything that's existed before, right? The world is broken in many ways. We have to work to improve what we have. That's our starting place. I could never imagine entering a country or a city or a hospital or something and saying, actually, we just need to tear down and build up from scratch again. But it might be nice if we had the resources, but I think you're right. It is there. Now, what can we do to make it better? What can we do to constantly redesign that and make it better? So I'm conscious of our time. I want us to move to another tool, which is time-bound, unlike the linkager process, but also gives us an ability to see inside the system. So if we have the ability to articulate each of these processes, okay, we can start to see the complexity that exists within the organization or system that we're trying to improve. Okay? The next step then is to actually see individual processes, the things that we're going to focus on improving. Right? And for that, we would use a process map. Okay? You guys have probably heard it referred to as other things: flow chart, causal loop diagram, value stream analysis. You guys heard those terms before? Right? Pretty straightforward, right? This is a way now of saying we're actually going to get away from the big picture view. We're going to drill down into a very specific focused area. Okay? And we can do that using some of these tools. I'm not going to go through this, but process maps have a very specific language that they use. Certain shapes mean certain things. And you'll have this so you can check it out later. Okay? Here's a very simple one that doesn't use all that complex language. But here would be an example for PMTCT care, okay? Prevention of mother-to-child transmission of HIV. Right? Very simple process map here. Here we've got 5-6 steps to providing care to reduce transmission of HIV to children. Okay? Very, very simple. It shows us now the outcome that we might be measuring, the process measure in this case, might be our transmission rate. Okay? But at each step, we could measure how we're doing. We could see how we're doing in terms of providing HIV testing. We could see how we're doing in providing dual therapy or ART to pregnant women. Okay? We could do all of that as individual measures or step measures within a particular process. So that's an example of a process map that helps us to get in. And if we found that we were sort of falling down here, our inability to conduct lab tests, okay, then that's where we might focus our improvement. But again, data becomes critically important for showing us our current performance and where we want to focus our improvement and helping us to reevaluate our assumptions. Okay? So we see a high transmission rate and we make an assumption about that transmission rate. Right? But what this does is it allows us to go in and figure out exactly where the problem is. Right? It gives us a starting place for that. And we can measure each one of those steps. Here's an example from data flow. Okay? Some work can be around the information that's flowing through a system. Right? Patients flow through a system, but so does information about them. Right? And that can be critically important as well. I mean, it's a terribly important thing. It's the focus of why we're here. We need information. We need good information systems in order to understand performance so that we can improve care delivery for patients. Right? If we are having mistakes take place in the transfer of information or even in the recording of information at individual locations, then we're in trouble. Right? So as much as we might map a care journey for an individual patient, as in the process map before, we might want to map also the data journey. Okay? And so as you think about your projects, you might think about how is data moving for what we're for us. You know, what is the information? Where is it first being captured? Is it being aggregated anywhere? Is it moving from one location to another? Because just like a patient, data errors can be introduced whenever there's a handoff. Right? Whenever there's something that's different or changes, we see that all the time. Okay? We see big errors get, data entry errors, right? All that kind of stuff. So data has its own flow as well. Having the ability to map that can help us to target where we would like to leverage improvement, where we would like to make a change to our system. All right. How are we doing on time, Leo? Good?
Half an hour.
Oh, really? All right. All right, setting names. So this is the beginning. This is where we've articulated what we believe, and now we're gonna start off and say what it is we want to accomplish. Okay. So here's something about setting a name. If you want to improve a data system or you want to improve a care system, I'm going to challenge you with this statement. Whatever you want to accomplish should be impossible within the current system. Should be impossible. Now, a lot of people will laugh at that. Why would you say that, Brandon? Why do you guys think I said that? Yeah.
Your definition earlier sort of implied that
Exactly. Every system perfectly designed to achieve the results it gets. That's right. Wouldn't need changes if you were already achieving, right? So that's what I mean by impossible, okay? It requires transformational change. It requires you to do something that is fundamentally different than what's happening right now in the status quo. Right? So that transformational change is a redesign of the system or a redesign of an individual process within the system. Okay? And that fundamental change will yield a change in performance. Right? Better or worse. Okay. So in terms of when you're setting a name, it should be ambitious. It has to be measurable. Okay? It needs to be time limited, and it needs to be as specific as possible. Right? So often we come across improvement initiatives that are vague. Right? What's an example of a vague improvement initiative? I would love to reduce child mortality in the world. That's vague, right? That's not an aim. That's something else. I'm not sure what that is. I want to reduce under 5 mortality in one district by 40% by January 2012. Now that's specific, it's time limited, it's measurable, right? It gives me a geographic location to fixate on. Right? Now we're talking about something that we could actually start to wrap our minds around. We're starting to draw that circle around our system where we're going to put the boundaries of what we try to improve. Okay? Does that make sense? All right. Yes?
Shouldn't you already understand the system before you try to change it? Like if you set your aims before you actually understand the system, isn't it backwards?
I would argue yes. I mean, I think if you don't know anything about your system, you probably don't want to change it because you're likely to make it worse, right? But lots of people don't think that way. Lots of people just see an outcome that they don't like and say, well, I've got some assumptions about why that is. Let me put some resources towards it and see what we can do to change it without that deeper understanding. Yeah, definitely. Yeah. Good. All right. So, what are you trying to accomplish? Time limited. So how much and by when are the kind of things that you want to focus on. So what I would challenge you to do with your project teams, right, is as you get together for the first time, think about the system. Where are you going to draw your circle, right? What are the processes that you're working with, or even just a single process that you're working with? And then what do you know about it? What information do you have that can inform the development of a name? So for your team, and you think about your project, what are you trying to accomplish? Be as specific as you possibly can. You got a few weeks, be specific. Yeah?
You're saying to be specific on a process, but on a system perspective, like just focusing on the process is enough to change?
It's enough to change.
A linkage of all
Yes,
processes.
definitely.
Just focusing on one, is it
So I agree. For the purposes of here, learning about process improvement, this is your learning laboratory. This is your opportunity to learn about quality improvement. You're asking a very fundamental question, which is, how big of a circle do I draw? Do I draw it around a single process? Well, if my focus is on learning, yeah, because that gives me something manageable. If my focus were to actually change the outcome of a system, then I'm going to need to expand that circle to include some other things that are going to be participating in driving the outcome that I'm looking for. Absolutely. And that is a fundamental question that every quality improvement team has to answer. Right? Definitely. If you're a CEO or you're a minister of health, it's a really hard question because now you're saying, how do I do that strategically? How do I choose which parts? Do I improve maintenance? Do I build a building here? Do I improve the clinical process of care over there? Can I get those things to line up and work together? Right? That's going to be a different question. It's going to be a hard question to answer. So think about this. This is my challenge to you. Okay? All right. When you're reviewing it, there's some key questions that you can be asking to yourselves. Okay? Is it specific? Is it ambitious? Is it clear to anyone who will read it? Right? So if you just went out on the street and said, hey, read this, do you have an idea what I'm trying to do? They should be able to say yes. They should be able to read it and say, yeah, I got a good idea of what you're trying to accomplish. Right? If it's like that, it's a good indication that you have a good handle on what it is you're trying to accomplish. You have a good handle on the system that you're working within and that circle that you've drawn. Okay. And then ask people to improve it. Ask them, where could it be clearer? Where could I improve this? Where could I make it better? Okay. So the last thing I want to talk about today is the model for improvement. And this is a very specific model that is developed from the work of Walter Schuhart and Edwards Deming. Okay? And it's a mechanism for actually making changes in a system or in a process. So it is, in my mind, a really powerful mechanism for driving quality improvement. It's not the only mechanism, but it is one. Okay? So again, now we're focusing here on theory of knowledge, constantly learning. The model for improvement in many ways is the application of the scientific method through quality improvement. And it's a way of engaging teams of people and helping to understand their perspective and getting them motivated to change. Okay, here it is. It's described in the improvement guide. That's Langley et al. There's a reference at the end. Okay, it involves 3 questions and something called a plan, do, study, act cycle. So we'll talk about the plan, do, study, act cycle in more detail in a minute, but what I want to focus on for the first part are the 3 questions. So when you're approaching a quality improvement project, the 3 questions are critically important. What are you trying to accomplish? You can do this at the macro level for the project itself, or you can do it for an individual learning cycle. Okay, you can do it for an individual learning cycle. What change can we make that will result in improvement? So coming out of our assumptions and our thoughts and the information that we have about our system, what are all the things that we think we could do differently, that we could change about the status quo? Okay? And then how will we know that a change is an improvement? How are we going to measure whether or not what we're doing differently is better than what is right now? Does that make sense? So those 3 questions are important. All 3 of them are important. So that measurement piece is going to inform whether or not the changes we made are good and whether or not we should try something else or evolve our theory, right? Or even change our focus. All of that, when you have them in place, then get driven by the PDSA cycle, which is a mechanism for testing change in a non-threatening way to a system. Okay? All right. So this is really the aim setting. Yeah, Patrick?
Can you make a difference for me, a distinction between act and do?
Yes, we're going to talk about that in a lot of detail in just 2 minutes. Is that okay? All right. Definitely. Hold on to that, though. Don't let me get away from that. All right. Okay, so what are we trying to accomplish? Project aim. But then, when we have come up with a specific change that we want to make, a specific aim for testing that change, right? If my aim overall is to reduce HIV transmission, but the change that I'm making is one to increase HIV testing, then I need to have an aim just for that, right? I need to have an aim just for that. So it's maybe increasing testing by how much, where, for what population, all that kind of thing, okay? What change can we make that will result in an improvement? So where do we go out and find change ideas? How do we know what to do differently? Here are some ideas, okay? The first place that I'm always going to look if I'm working within a system is to the people who are providing the service. Remember what I said way back at the beginning about subject matter experts? These are their subject matter experts. These are the folks who may be researchers in the field and have real deep knowledge about what works and what doesn't work, or they could be frontline caregivers who are running into systems barriers every day, who are running into things that they don't like, and they're having to work around those barriers, right? They're going to be a good source for understanding what you could be doing differently. Walk into any hospital in Boston after class today. Pull aside one clinician and say, tomorrow when you come to work, if you could do one thing differently, what would it be? You would have change ideas coming out of every pocket. I mean, people have things that frustrate them about their job, and they have solutions, but often they don't feel empowered to enact those solutions, right? So one place to look for those ideas is from the people who are living it every day. The clients themselves, particularly in healthcare, right? We often forget about patients. We're so focused on the system and the caregivers that we forget about the patients themselves and their needs and the challenges that they have to accessing care, particularly in resource-constrained environments. Right? I've worked with clinics where people have to travel 50, 60, 70 kilometers, right? all before 8 a.m., and then wait to get care, and then travel back at tremendous cost, right? To themselves, to their family, to their work, whatever it is, right? Are we taking that into account? Clients can have ideas about where we can do things differently and how we can improve our systems. Of course, best practices and guidelines are important. We can't forget, that guidelines are in place for a reason, because people have done some serious thinking around the topics and the processes that we're trying to improve. And a lot of places have good policies and guidelines in place. We develop great recommendations frequently at places like UNICEF, World Health. Individual ministries of health come up with great guidelines, right? Now, their reliable implementation is a completely different matter, but there could be some great ideas contained therein about how we can improve systems, okay? Change concepts. These are something that you can learn more about, but things that could lead to lots of different specific ideas, okay? Improve throughput, eliminate waste. These are concepts, but they could be leveraged into very specific actionable items. Okay. Now you can use structured creativity. There's great thinkers, people like Edward de Bono, who have done a lot to help us understand how we could use structured creativity, right? A lot of people think, well, that person's creative and that person's not, right? But actually, we can all be creative if we learn some tools to help us overcome our normal perceptual sort of ruts that we get into. Okay. And doing some root cause analysis, right? Understanding the process, talking with folks about what's wrong can often lead to ideas. Last bit, how will we know that a change is an improvement here? We've got to measure. We have to know for an individual step in the process or for the whole process itself or for the outcome for the whole system, how we're doing. This often is neglected by folks. Right? We're interested in the patient that's right in front of us, but we need to have the perception, we need to have the awareness of what's going on around us. Okay? So each change idea has to have measurement associated with it. If I'm going to implement a new data system, how am I going to know that that's better than the paper-based system I've been using for the last 20 years? What do I know about the performance of the paper-based system that tells me that I need to change away from that? Right? You've got to have a way to measure so that when you do something different, when you try it out for the first time, you know that it's an improvement. So, Patrick, coming to your question. What about this thing? What about the Plan, Do, Study, Act cycle? So a lot of times it's called the Deming cycle. Deming called it the Schuhart cycle. He said he got it from Schuhart. But really, this is a way of what we call rapid cycle learning. It's a way of learning very quickly whether or not the idea we have will work. And I'm going to tell a story in just a second about that. It starts with a plan. Okay? It starts with a specific aim for that particular change idea. Okay? We state the objective, what it is we're trying to accomplish through that change idea. We're trying to increase HIV testing. We're trying to increase immunization rates, whatever it is. Then we start answering some very specific questions. We start answering questions like, who's going to try this out? Right? Well, it's going to be Nurse Judy. Okay? She's going to try it out. And when is she going to do this? She's going to do it on Monday morning at 9 a.m. Okay? And where is she going to do it? She's going to do it at Clinic X. Okay? And who is she going to do it with? She's going to do it on the first 10 patients that walk in that day. Okay? It becomes very specific. It's like planning a small experiment just for a single small moment in time. Right? We're not talking about a grand plan to redesign the entire system in one cycle and it's going to take us 6 months or a year. We're talking about something very, very small, something we can accomplish in one day or within 1 week. Okay? Something very, very rapid cycle learning. It's all about right now. Okay? So we're going to plan that out. We're going to articulate all of that. We're going to write it all down. And then we're going to go out and we're going to do it. So Nurse Judy, Monday morning, 9 a.m., she's waiting there for the first 10 patients at Clinic X to come in. As those patients come through the door, she's going to test this particular change idea, whatever it is. Okay? It might be a new data collection mechanism. It might be a new way of immunizing patients, whatever it is. Okay? And then she's going to document everything that's going on. So she's going to document not only the measurement that we have articulated in the plan, right? But she's also going to document anything out of the ordinary, anything that she's learning that she hadn't predicted, anything that is against the assumptions that she made or that the team made together. So she's going to capture that information during the do phase. Right? Now the study phase is where we start to look at what we learned. And the study phase builds upon a very important part of the plan. Now the second bullet in the plan there, it says make predictions. Nurse Judy and her quality improvement team, when they're planning what they're going to do on Monday morning, they're going to make a prediction about how performance will change for those 10 patients. Okay? And they're going to write that out. All 10 patients are going to get their immunization today as opposed to the 5 who got them last week. Okay? They're going to write out that prediction. When it comes to the study phase, they're going to compare. What did we learn that we didn't anticipate, and did we achieve what we predicted we would? Okay? And if not, why not? Right? We're going to lay all that out and ask those questions and have that conversation Monday afternoon during our lunch break. Okay? And then we're going to make a decision about what to do next. If that change idea was successful, we might decide, that's great. It worked really well. We want to try it again, but on a larger scale. Instead of 10 patients, we're going to scale it up to 50 patients. Okay? So that's what we're going to do during the action phase. If it works marginally well, but we think we learned how to do it better, then we might say, instead of adopting this, we're going to adapt it. We're going to run it again on 10 patients on Tuesday morning, but with this slight alteration, right? Because we learned something during that study phase about what worked and what didn't work with the first 10 patients. Okay. Or it might be a colossal failure, and that's totally fine too. That's absolutely a fine thing. So if it failed, then we want to talk about that, we want to embrace that, and then we'll say, okay, well, why did it fail? What does that tell us about how we should change our assumptions? How should we change our theory? And what different idea would we like to change or like to test as a result? Okay? So what different idea do we want to test as a result? Right? And then we're going to do that on Tuesday. Make some new predictions and make a new plan. So we can do all of that through the PDSA cycle. Okay? All that's very, very specific. This has been done for 70 years in manufacturing. Right? Toyota runs, on average, 1,000 PDSA cycles a day in their manufacturing plants around the world. Okay? In healthcare, we're still learning how to do this. And we have some special considerations, right? We're not building cars. We're working with patients. So we always need to make sure that we're not doing things that could harm patients. But there's lots that we can do in terms of changing data systems, changing the flow of a clinic, changing the order in which we do certain things that's safe, but still needs to be tested to understand if it will impact the reliability of care that we're providing. Okay? So that's the PDSA cycle, and that's the second half of the model for improvement. Okay. All right, so my second challenge to you is to develop a PDSA with your team. Right? It could be a PDSA to see if you've got an idea that can improve something, or it could be a PDSA simply to learn about the system that you're trying to improve. Okay? But I would challenge you with your project teams as you start to think about things, how could we use this methodology? How could we use a PDSA cycle to learn about how to improve the data systems that we're working on? All right. Here's a potential form you can use. I can give this to you if you want, of how you can write things down and have a data capture tool for each individual PDSA cycle. Okay? And like I said, you want to slowly build up as you go, right? Actually rapidly, but as fast as you can. Right? Some hospitals will do 3, 4, 5 PDSAs a week on an individual process, right? Maybe 50 across a whole hospital. It's great. So here's Julie. Julie is a nurse that I had the opportunity to work with in South Africa. And I wanted to give you a real-life story of how we could use PDSAs. Okay? So Julie is a fantastic nurse. She's an HIV nurse. And she was focused on voluntary counseling and testing of HIV services. Right? And Julie is a tremendously hard worker, really devoted to her community. And as we started to increase VCT, we started to increase the total number of people who were testing HIV positive, we had perfect performance on testing. But that led to a huge influx of new patients who needed treatment, unanticipated consequence of improved care. Right? Nothing wrong with that. That's a good problem to have. But now we're overwhelming our chronic care abilities. And Julie was working at a hospital where they were starting to see upwards of 300 patients a day just to provide chronic care, let alone new patients who are coming in the door. Okay? So we had this problem where we had so much chronic care going on that we were running out of resources to provide care to new patients. And we were starting to build up a queue. We were getting a line of people who were waiting to get onto treatment. So this was quite a while ago, and we thought, well, what can we do about this? And Julie said, well, we've got all these clinics that refer patients to us for care. What if we started doing chronic care at the clinics? Okay? What if we did chronic care at the clinics instead of here at the hospital? That could free up space for us to initiate new patients onto treatment. So that's a great idea. That's a fantastic idea. How are we going to do that? No one had ever done that in this particular district before. So how are we going to do that? Nobody knows how. So we said, well, let's plan a PDSA. We came up with a 7-step plan. It involved things like making sure we had the drugs prepackaged and sent ahead of time to the clinic, notification of the patients, make sure that they were ready and willing to accept treatment at a clinic instead of at the hospital. There's 7 steps that we had in place. And we said, okay, all right, Julie, we're ready. On Monday, we're going to try it with 2 patients. And so we did. We had 2 patients who were willing participants, and they said, yes, we would like to try to get our treatment at our local clinic instead of at the hospital this month. So those 2 patients went, and wouldn't you know it, only one of them got their medication. So we predicted both of them would get it, and only one did, so we said, what happened? And we did, during the study phase, we examined the situation, we realized that we had missed a step. We had missed a step in connecting the pharmacy with the clinic. Okay? And so it was a failure. Now, it was a really good idea, but if we had gone to full scale right away and we'd had a 50% failure rate, that would have been catastrophic for our HIV patients. Because it was 2 patients, it was real easy to just call that patient up and say, hey, come to the hospital tomorrow, we'll pay for the taxi fee, and we'll get you your medication. Now, we learned what happened. We fixed that. We went from a 7-step to an 8-step, and the following week, we down-referred 5 patients. 5 patients. Worked great. All 5 patients got their medication. We felt good about that. We learned a few more things. So the next week, we down-referred 15. Right? Worked perfect. No problems. The next week, we down-referred 50. Right? It took us 5 weeks to go from 0 to down-referring everybody in that particular catchment area to their local clinic. Okay? But we were able to do that using the PDSA cycle and learning about what the limits were of our implementation. So it's a good example of how you can scale up and learn quickly about improvement in your system. All right, so what's the lesson there? You also have to think ahead, okay? Because with scale comes new problems, unanticipated problems. When you're working with 1, 2, 5 patients, pretty easy. You can call them up on the phone. You can get them on a taxi. When you start working with 50, 100, 1,000, 10,000, you have new problems. So if you're using the PDSA cycle, you always want to be thinking 2 or 3 steps ahead. When I scale this up, what's going to happen? Right? Is there going to be a failure here associated with scale that's going to introduce something that we're not anticipating? Right? If you can do that early in the process, you can start to plan for that, make adjustments to the change idea. All right. So knowing when to implement a change is critically important, okay? There's times where you're developing change, times where you're testing change, and times where you're implementing change. Implementing change is different than testing. You have a great idea, you're innovating something, you're testing it out. You think this is fantastic, this down referral process at a Shawway hospital, fantastic, right? Great testing. Now we're ready to implement. Now what are we talking about? We're talking about changing policy. We're talking about rewriting job descriptions, right? We're talking about developing new training curriculum. We're talking about re-education of the workforce that exists, right? All of that, which is not in the mainstay delivery of care, but is in the support processes, is in the redesign processes. Implementation is a whole different animal. So when you get ready to take that new idea to implementation, you have to think about all of those different things that are going to come together to make sure that that change idea continues to be a success. One of the failures of lots of projects is they have a great idea, They go in, they try it out, they start using it everywhere, and then what happens? The money runs out because the funder is moving on to a new cycle, and nobody bothered to change the job description. Nobody bothered to rewrite the policy. That new group of doctors rotated in from a different place and didn't know anything about it. And suddenly that wonderful change is lost. Right? So implementation requires us to pay attention to those details, those things that we're going to encounter, particularly in resource-constrained environments where we have turnover. Okay? So this is from the improvement guide as well. It's a great little table that I would refer you to when you start thinking about if you wanted to implement an idea, when you should do so. There are 3 key factors. Okay? One, are people ready for change? Hugely important, right? That's the psychology component when we talk about profound knowledge. Are they resistant, are they indifferent, or are they ready? Right? If people are not ready, you're not ready to implement. Okay? If there's any kind of resistance at all, you're still looking at small tests of change. 1 patient, 2 patients, 1 week, 1 day. Okay? Do you have confidence? Do you have a high degree of belief that this change is going to be beneficial, that it's going to be better than the status quo? Okay? If you don't, more testing is needed. Okay? And then the third is, what is the cost of failure? Right? Now this could be financial cost, or it could be time cost, it could be human resource cost, it could be cost in terms of lives. Okay? So what is the cost of failure? Right? Is it high or low? Implementation is only ready when you have a high degree of belief that what you're doing is better than the status quo, the cost of failure is low, and people are excited and ready for change. Right? So it's an assessment of all 3 of those things. Does that make sense? So as you think about your projects, you think about what you're going to change and what you're going to take potentially to scale, having thoughtfulness around these things, as well as what are the implementation issues associated with introducing a new technology, a new process, a new system, whatever it is going to be critically important. All right. I think we'll stop there. I threw up the discussion questions from the syllabus, but we'll stop there. Question? Yeah, Elliot.